Good morning, everyone. How are you? We've been looking forward to this session. Earlier this morning, you heard about how important CDC really is around the issue of global security. But you know, government simply cannot do it alone. We need business. We need the full spectrum of the nonprofit sector working, first of all, on their own, but more importantly, with each other, and then across sectors to really make the impact on improving public health that we need to make. We talk so often about partnering and partnerships, but it can be difficult. And what we'd like to do this morning is share with you a few of the lessons we've learned working in the nonprofit sector about how this partnering takes place. How do multiple nonprofits actually align and find that common ground where they can move forward as one to make a real difference on the population's health? It's much easier said than done. And to help us do that this morning, we've really got an outstanding panel of presenters. What I'd like to do is introduce them first, and then we'll start with an overarching question that they can each speak to for just a bit. First of all, to my immediate left is Dr. Jim Marks, a good friend who taught me about Atlanta when I first moved down here to start the foundation. Jim worked first at CDC, but now you're Senior Vice President for the Robert Wood Johnson Foundation and Director of their Health Group. Welcome, Jim.
Thank you, Charlie.
Next is Dr. Anna Barker, who's Director of Transformative Healthcare Knowledge Networks and Co-Director of the Complex Adaptive Systems Initiative at Arizona State University. Ann, it's great to have you. And you know, at CDC, we're really famous for acronyms. We need to come up with an acronym for that name, for those job titles. I got to tell you.
I'm from long in the government. I'll come up with an acronym.
Good. We'll come up with something. Next is retired Ambassador John Lange, who currently serves as Senior Fellow of Global Health Diplomacy at the UN Foundation.
Thank
John,
you, Charlie.
It's great to have you.
Thank you.
Also, we're pleased to welcome Dr. Lynn Goldman, who's Dean of the School of Public Health at George Washington University. Lynn, great to have you. And last but not least, Dr. Larry Jameson. And Dr. Jameson is Executive Vice President of the University of Pennsylvania's Health System and Dean of the Raymond and Ruth Perlman School of Medicine. So an outstanding group of panelists this morning from a very broad spectrum of work in the nonprofit area, from NGO to endowed foundation to university to public charity. And so I'd like to start by asking each of our panelists to answer the following question. Based on your personal experience in working with nonprofit partners to improve public health, what examples can you share? And what lessons have you learned related to finding the common ground so necessary for success? Jim, you want to start?
Sure, Charlie. Thanks. I think the key thing I want to think of when I think about working with nonprofits, one of the things that surprised me the most in moving from CDC to philanthropy was how similar we were. We didn't have enough money to do the kinds of change we wanted to have happen. For us, we think the change needs to happen all across our nation. We're largely a domestic foundation. How do we have that occur? It's with who we partner with and their reach and their scope. So I'm going to give an example. We've worked pretty extensively, this is just one, but we've worked extensively with the YMCA. The YMCA did not have childhood obesity as a central part of their mission, but they did have youth development, they had wellness, and they were beginning to say, we need to do more in our communities outside the walls of our facilities and our pools and all of that. So we supported them to look at local policies they could be active in, and then to say when they had multiple Ys in one state, to start to have state policy discussions and influence. They've been an absolutely terrific partner. They're in 2,700 communities. They see more children a day than McDonald's. So for a relatively modest investment on our part, and working with them on what was important to them where they sat. And you really have to respect that the people you're going to partner with will have somewhat different mission than you do, but you'll have shared areas, and to build on those shared areas. And they have, as I said, they now have policy as part of their agenda. They report back on what they've changed in their communities. Some are small, some are large. They also work at the state level. And so we end up having them as a major strategic partner for us, and we're starting to think, are there other ways? They're not the only one, but when we say, if we don't have enough resources, and we're concerned about things in the communities, and we want to do it in more than 6, 8, 10, 12 communities, we've got to look to partners that have reach and influence around the nation. So the why has been a good one for us, but that's the way we think of nonprofits.
So you're an endowed foundation in the nonprofit sector. You're reaching across to essentially a nonprofit membership organization.
Yeah.
Any surprises or lessons learned in terms of bridging that gap as you try to work out an approach with these folks?
So a great question. The key thing for us, again, it paralleled very much my experience at CDC. CDC has relatively limited authority over state and local health agencies or others in health. Even every national organization has its affiliates, some of whom are out there as leaders, some of whom they need to bring along, but who often have their local relationship. It takes time to change a large organization, to get that alignment within an organization, and then for them to be a powerful voice throughout all of their affiliates. That takes time. You have to respect that that takes time. And it's not different from any large organization. But it's crucial that you invest that time if you're going to try to change. We're saying, how do we change the nation to a culture of health? We know we can't treat ourselves out of our current healthcare cost crisis.
Ann, you want to talk about your experience in a university setting around partnering?
Yeah, my current experience started when I was at the NIH, or the National Cancer Institute. I was the deputy director there for about 8+ years, and I did a lot of the kind of alignment that we're talking about this morning, creating programs that actually brought groups together, disciplines together, and sectors together. And in leaving the government, I went to Arizona State University with a problem on my mind. Working with FDA, we're at this inflection point where we're all talking about precision medicine, but in fact we face a huge barrier in that we haven't sorted out how to take that information and turn it into a biomarker. So what is a biomarker? A biomarker is essentially a biological signal. We can measure it in genomics and proteomics. We have all these wonderful technologies today to do this, imaging as well. But what we don't have is any kind of pathway to develop a biomarker. There is no way that the communities have actually agreed on. By the time you discover a biomarker, mostly in the academic environment, it has to get passed through a series of sectors to actually end up at the FDA. And currently, pretty much everything fails. We approve about 1.2 biomarkers per year at the FDA, and this is a problem we worked on long and hard when I was at NCI. Hasn't gotten any better since 1993, and we use less than 100 of these in clinical practice today. And this is going to be one of the foundational elements of precision medicine, and I would argue of the whole public health question in terms of prevention. So can you solve this problem? Well, yeah, you can solve this problem. You just have to get people to the table. So when I went to ASU, we have a very innovative culture there. The president said, let's do this. So we set up a new nonprofit, and we have spent the last 18 months analyzing the problem. We want to stop studying the problem now and get on the ground and fix it. So we've set up a new network construct where people are coming to the table to do the demonstration projects, to actually do the work, to establish a very, very visible and transparent pathway for the different classes of biomarkers that will drive the future of medicine. So this sounds like an extremely sort of boring kind of problem, but it's really necessary that we do this, and it really does require that we break down silos, not just in the academic setting, but also in the way nonprofits are playing in this space, the disease nonprofits especially, and the way the private sector is relating to all of these other groups. This is also a very major economic issue, because if we can solve this problem, then your targeted therapies are going to actually be predictable, and all of our phase 3 trials will stop failing. And if you start thinking about the diagnostics industry in this country, it's pretty much dead at the moment for molecular diagnostics, because these folks can't make money on their new diagnostics. This will actually start to level the playing field. So it's been a very interesting experience to do this out of an academic environment, but I would say from a nonprofit perspective, it's actually been a lot easier than it was to do in the government.
You talk about silos and needing to align. How do you get everybody to play in that space and to play by the rules, play together?
That's an interesting question. I've been studying that problem for 30 years. I think it depends on the nature of the problem. Because if the problem is big enough, if you think back to sequencing the human genome, Francis Collins will tell you that everyone said it couldn't be done. And of course, it's done. And he and I started the Cancer Genome Atlas, which is essentially the same project a few hundred times over to sequence all the cancer genes. And guess what? Francis came to our board meeting and he showed the same set of slides that he had showed when we started the Human Genome Project. The same criticisms applied, couldn't be done. So the problem has to be big enough and important enough to engage people. Everybody has to have skin in the game. It's not always about the money. In the particular case that I'm talking about, it's mostly about intellect and capabilities and people being able to share, and also taking risks and everybody being able to reap the reward when you actually overcome one of these barriers. And so the other thing I'd say is that you really need people who are committed. So we go to lots of meetings, we go to meetings like this, we go home, we don't remember exactly what we said we'd do there, but you really need to commit, and you need groups to commit in the future, I think, to networks, because I think the future of science and the future, I think, of public health belongs to network constructs, knowledge networks. Everybody's connected now, so we have to use that connectivity to build the knowledge we need to overcome these kinds of problems. So I'm very optimistic, actually, about the way this could work and should work. And I have a great friend who says that silos subvert solutions, and he's right. So if you don't take away anything else from what I said, silos subvert solutions. And I think the idea of breaking these silos down really involves people being committed, actually putting skin in the game, showing up, and doing the work.
Great, thanks. John, I think more than any of us up here on the stage today, you've got a global view of the world. First as U.S. Ambassador to Botswana, then working with the Gates Foundation on so many global projects, and now with the UN Foundation. So I'm interested to hear, what are your prime examples, and what do you draw from that in terms of advice for us trying to learn how to align on a global scale?
Thank you, Charlie. I think at first I'd like to talk about a specific example and then talk about a broad framework, all relating to alignment. The Measles and Rubella Initiative was started in 2001, and it involves the American Red Cross, the Centers for Disease Control and Prevention, the UN Foundation, UNICEF, and the World Health Organization. It pools their resources and their expertise from these diverse partners, and the goal being to eliminate measles. What's really clear here is that each of the partners brings unique expertise and agendas, and that alignment has been critical, that they have each partner play to their strength. So in this case, you've got the American Red Cross providing funding, advocacy, technical support. CDC has such vast expertise on technical and laboratory surveillance, and it provides funds for vaccines. The UN Foundation, where I now work, manages and coordinates donor proposals and provides funds. UNICEF has its logistical and procurement capacity to source vaccines. And then WHO, the World Health Organization, provides technical leadership and strategic planning and ensures that all the components of this strategy are technically sound and successfully implemented. And it's not just those organizations, but really over the past decade, the partners have included faith-based organizations and other UN agencies, civil society organizations, foundations, private sector experts, governments, etc. So what's the result? The initiative has vaccinated over 1 billion children, and the measles mortality in Africa has been driven down by 84%. In 1990, about 1 in 5 child deaths prevented since 1990 are due to the measles vaccination. So by having that alignment and relying on the expertise of each of the entities, it's really been a key. The other thing I think that I'd like to raise is this broad framework that's being developed, because it could really drive a lot of development assistance and emphasis in developing countries in the years to come, and that is what's called the post-2015 framework. Many of you are familiar with the Millennium Development Goals, and these goals were started with probably lower expectations than they ended up resulting in, because there's been a great focus on governments and in the United Nations system to meet the goals that are to take us through the period through 2015. On the health side, that includes some key goals on reducing child mortality, improving maternal health, and halting the spread of HIV/AIDS. They haven't all been successful, but they really have galvanized the international community. And what it does is it serves to prioritize global and national development efforts. Well, the next set of goals are under great debate all over the world, it seems. Certainly last week I was at the World Health Organization in Geneva, and Dr. Margaret Chan, the Director General, was speaking very strongly about her views on how these goals need to be developed to include universal health coverage. And this framework is going to be a really important guide for governments and nonprofit organizations and others who are involved in the development field. It's under debate in the end in New York within the United Nations system. But really all organizations right now are encouraged to provide input on this. There's been a lot of different ways to do that, including some universal health coverage indicators that the World Bank and WHO have put together that are on the web, and they're asking for input by the 15th of February. So I think that this broad framework is in the long run going to provide some clear guidance and direct funding for certain areas, and that's an area of alignment that everyone really needs to be looking at and be aware of.
Thank you. Lynn, when I think of a school of public health, I think and we all know you're a teaching institution. You're helping prepare the workforce for the next great people who are going to be working here at CDC. I think we think less about you touching the communities where you live and really needing to align with anyone else in terms of doing your duty. Can you speak a little bit to the importance of alignment and how you go about doing it at George Washington?
Yeah, I sure can. And I do think it is so important that schools of public health do create partnerships with the community. If you think about the public health research that we do and the need to translate that into practice so that there actually is improvement of health of people in the community. But in thinking about it, I realize there are a lot of different ways that we've tried to do that, at least at George Washington. First, with the problem of HIV/AIDS in the District of Columbia, which is among the most serious problems in the country, that there's pockets still of HIV/AIDS transmission. They're so serious. And we have actually embedded epidemiology professors within the Department of Health to work with them to build the surveillance systems and the prevention efforts in partnership not only with the DC government, but also the CDC, not-for-profits, and others in the area. And we've seen remarkable success in starting to turn that epidemic around. Another example is the example of obesity, another major public health issue in this country today. And actually Sanofi, who's here today, has partnered with us to create something called the Stop Obesity Alliance that brings together many parties, governmental, industry, others, to work to find creative ways to not only prevent obesity, but also to treat obesity, people who have obesity. The hospitals and the work that they do for community health, Robert Wood Johnson Foundation has partnered with our school. We are working with them to develop a web-based tool that all of the not-for-profit hospitals in the country will be able to use, not only to report what they're doing to benefit community health, but also, if you may, to assess the actual health impact, the actual impact on public health of that work. Because I think we all feel that we not only want to see the charitable deeds being done, but that those actually result in real benefits, real impacts for communities. And last but not least is smoking cessation. Even though we've been very successful in the US in reducing smoking, there's still 17% who continue to smoke. And one of our faculty developed a web-based, actually a cell phone-based tool called Text to Quit that is being deployed in partnership with a company that produces this kind of software, but also healthcare systems and insurance companies who are deploying it. We now have 75,000 people using this app. We've seen something like a 32% success rate in quitting. And it's been a remarkable partnership that I think is beginning to bear fruit.
How do you incentivize professors who are used to thinking about their issues, their funding streams, to think outside that box, be flexible, be willing to align?
Well, I do think that this kind of work requires some new models for how we do work within the university. Certainly, professors need to be rewarded for doing collaborative work and not just their own individual research. So the traditional academic model of promotion and tenure being based only on individual achievement, we're working to replace that with finding ways in the process to recognize collaborative work, but also frankly fixing some of the administrative systems around the university, because if it's just too hard to do it because the university can't handle the partnerships with the foundations, cannot handle partnering with the government or not-for-profits, then the professors are disincentivized from doing this work. And we've worked very hard at GW to become more responsive to our partners. And last but not least, for our institution as a whole, to realize that we sometimes have to cede our identity to a broader partnership. So this work on HIV/AIDS, as much as our university would love to call this the George Washington Center for AIDS Prevention, we call ourselves the DC Center for AIDS Prevention. And what that does is it creates a broader tent that others can come into, including people from other schools of medicine and other universities in Washington, D.C., who we desperately need to have join with us in order to address the epidemic. That is not as easy as it may seem. We talk sometimes about ecosystems that we're part of, and certainly Washington, it's a major ecosystem in terms of public health, but ecosystems sometimes exert a very powerful control, and it seems obvious, but the hardest thing to do, and I think one of the most important things to do to become a good partner, is to learn how to share credit, how to share responsibilities.
Thanks. So Larry, you not only are dean of one of the top medical schools in the country, but you also head up a major health system. So you've got a lot of parties and a lot of players in this, quote, nonprofit sector. How do you go about getting people to work together? Any particular experiences you want to share or lessons learned?
Well, thank you, Charlie. Anne emphasized the point that you need to identify a compelling problem. And while I myself am a basic scientist and I'm fascinated by the advances in genetics that we've had, I also recognize that behavioral health remains one of the greatest unsolved challenges that we face. And so I'd like to share an example of a project we've been working on at the University of Pennsylvania. And it goes something like this. For every 1 hour that a patient spends with a physician, they spend another 5,000 hours outside the physician's office. So we have to think about those 5,000 hours. What's happening in that space and time? And how can we do a better job with those 5,000 hours of improving the patient's health? The strategies require two different types of alignment. It requires internal alignment within our organization, and then external alignment with other groups. So by internal alignment, what I mean is that Penn Medicine is an academic medical center that focuses on research, clinical care, education, and community engagement. But we need to have a strategy to prioritize the areas of focus. Because with 2,000 faculty, all of whom are passionate about what they do, we need to have internal alignment about where we're going to invest. External alignment will focus in turn on some of the community health groups, the Robert Wood Johnson Foundation that helps train people that get involved in these projects. So I want to divide our approach to focusing on behavioral health into two different categories. One category is an old one, and one is new. So this is a little bit about like a wedding, where you take some of the old and some of the new. The old approach has been to use community health workers and develop a series of metrics to assess their impact on things like readmission to the hospital, HCAP scores and satisfaction, sense of well-being. And so we've developed a very robust program that documents that we can reduce for hotspotter categories of patients. These are individuals we've identified at high risk for readmission. They're within a certain zip code. They're often on Medicaid or uninsured. They've got a burden of disease that we've identified. And the preliminary data looks like you can reduce readmissions by 15 to 50%, depending on the category of patient. And economically, it demonstrates that investing in community health workers provides cost savings to the health system. So the new approach is to focus on the 5,000 hours. And we've got a Penn Medicine Center for Innovation entitled Way to Health. This is the more high-tech version, where we've partnered with the Wharton School at the University of Pennsylvania to use behavioral economics as a strategy to team up with new IT strategies. So I'll give you one specific example. We know that patients, even after they've had a heart attack, don't adhere to their medications at greater than about 40 or 50%. So how can you move that up? One of the approaches has been to develop pill boxes that will sense when patients take their medications or not. And then inside the house, there's a device that will send this information into the study group in real time. But the real key ingredient here is to use the behavioral economics. So the team has set up a lottery system so that if you're complying, if you're adhering to your medications, you're eligible for the lottery. So someone might get a message that you won the lottery yesterday. The problem is you're not eligible because you didn't adhere at the 90% level. And so this has very quickly moved people from 40 to 50% adherence up to 90. And it's this partnership of different disciplines where you've got behavioral economics in Wharton with engineering skills to develop the pill boxes, with Robert Wood Johnson scholars who recognize the challenge of focusing on behavioral health and adhering to medications. So that would be a couple of examples.
Great. Well, before we leave our discussion about just the not-for-profit sector, I have to say that I worked in government for 22 years before moving to the nonprofit sector. I found it extremely freeing. It's such a different world. As each of you have either moved into that world or worked in that world, what are some of the really unique aspects that the nonprofit sector brings to solving problems and improving health? How's it different? What's unique? What can it do that nobody else can do?
Charlie, they have flexibility. They have the ability to change. They have the ability to target an issue. They have the ability to move quickly. They often have resource needs. And I too, going to the nonprofit sector from government, found that very freeing at the foundation. We have less resources, but we have greater ability to partner and to partner flexibly. You get to see what they need and why, how you can build a relationship that is, sure, it often has to have some resources behind it, but that isn't the crucial issue. And I think you stated early in the beginning, government can't do it all. In fact, we don't want government to do it all. We want it has to be a marriage between the for-profit, the nonprofit, and the public sector, and finding the best way that can happen for the big issues. Anna's comment, that's the only way we're going to solve the big issues, is with all of our sectors, all of the parts of our society, recognizing that we have to have health as a long-term outcome. But it's not health the way we often in health think of it. It's not freedom from illness. It is being able to have a good life, a life where you see your families thrive, where you feel safe, where it's fun to be part of that. If you're older, I have grandchildren. I want to see my grandchildren grow up, and I want to play with them. Some people may want to continue to work, even though they because it's fulfilling. You can only do that if your health is pretty good. And so that's the health is the basis from which you can make a lot of important life decisions. If you don't have it, it is more challenging for you, harder for you to succeed.
We've got a little less than 5 minutes left, and I want to expand beyond just the realm of the nonprofit sector, because the broader theme around this conference is public health and CDC at the center of public health. And so do any of you have any comments about CDC? How is it to partner with CDC? And any recommendations around CDC and its ability to partnership or the way it partners? Lynn?
Yeah, I certainly do. In my experience, there is no entity that is better than the CDC at building partnerships with the community for the promotion of health of populations. It is absolutely fantastic to work with them, and we're very lucky when we have the opportunity to do so. And at the same time, they have such serious budget constraints that too often they're not present, they're not at the table, they're not available to us to be good partners. Love to see attention being paid to that. I feel that over the last few years in particular, that the focus has been on paring them back to the bare minimum that they need to do in order to protect us from the most immediate and most severe threats. But if we're serious about enhancing the health of populations and dealing with the problems that we know are the most important problems of our time, whether that's obesity or communicable diseases, we need to see more support given to CDC. And we as universities need to be able to work with the CDC in the way that we now are capable of working with the NIH. That opportunity won't be there unless CDC has more resources.
Jim? And then Ann?
Charlie, what you look for in an ideal partner is expertise. CDC is really unparalleled in public health. And you look for leadership, that is to have the ability to reach the communities, the people you're concerned about, to help move the institutions. And you look for leverage, that is, can it take resources, you partner with them, and move it and make it more influential. The resource limitations at CDC challenge it for leverage. Your foundation has made it easier for us to work with CDC, but that leverage issue is one that resources are crucial to.
Thanks. Ann?
Yeah, so I was going to comment, when I was at NCI, obviously in the cancer world, we collaborate a lot and collaborated over the years with CDC. And I've always been so impressed with the fact that, and you saw it in the clip this morning from Contagion, that essentially you can move quickly here. And I never will forget the morning that I came into the NIH and somebody said, "Oh, someone sequenced SARS." And I said, "Oh, was that one of us?" And they said, "No, that was CDC." And it just reminds us that we have an agency here that actually does innovate, can move quickly. And I think in terms of partnering, another great example is, the breast cancer advocates went to the Hill in 2000 and said, we want all women to be screened for breast cancer, even if they can't afford it, and we want them to be screened for cervical cancer, even if they can't afford it. And now that exists in every state, all 50 states. And they went further to tie that into care for Medicaid patients, et cetera. So this is an agency that at its heart, it really is willing to collaborate to get things done. And that's really encouraging, in the government to see that. And so, I personally think the agency is totally underfunded, and maybe we can do something about that.
I'd love to see that happen. John, and then Larry.
When I was the U.S. ambassador to Botswana, the CDC operation there was run by Dr. Tom Kenyon, now the head of the Center for Global Health here, and one of my heroes in the fight against HIV/AIDS. I've also had a lot of experience dealing with the Global Polio Eradication Initiative, and you have CDC people on the ground. There are over 130 people working for CDC in Nigeria, including many Nigerians. That is a key, I think, and in the theory or in the rubric of the art of alignment. If you don't understand the economic and social and cultural context in the country, you cannot be effective. There are a lot of programs that are invented in Geneva and London, New York, Washington, and Seattle, and they're just far removed from the reality on the ground. And I still remember being, when I was ambassador to Botswana, having someone visit me from a nonprofit organization who said, this is what worked in Philadelphia, and I know it'll work here in Haberoni. And I'm sorry, that's not how it works. And what CDC really excels in is having that presence in countries where it really works so closely with the ministries of health that they really know how to make that difference and get a big bang for that buck.
I know as an ambassador, you would agree with Colin Powell, who said that this country's greatest ambassador on so many fronts in many countries around the world is CDC. The way they go in, the way they work, they'll stand up that minister of health, help solve a problem, move to the background, let that minister step into the limelight. And it's a wonderful way to partner, to align. Larry.
I just wanted to underscore the convening function of CDC and pick up, John, on your comments about Botswana. After you kicked off the PEPFAR program there, I had the chance last spring, a decade later, to see what's happened, the transformation in that country. And the CDC has been a constant presence and convening force for multiple different entities that have joined in. Harvard is there, the University of Pennsylvania, Baylor, a variety of other groups. The CDC is the force that pulls them all together, helps with the collaborations, provides the biorepository, some of the sequencing capabilities, and catalyzes some of the research projects. And you look 10 years later at what you were able to catalyze, it's really impressive to see the mother-to-child transmissions dropping, the research on drug-resistant tuberculosis in different parts of Botswana and how the solutions to that will vary in different parts of the country has been driven by rigorous research, and the CDC is behind all of that.
Jim?
Charlie, I'm struck in listening to everybody here. Research turns fate, misfortune, bad luck into a choice. But then it turns it over to society and says, if you want the value from that research, you've got to get it out to all in need. And CDC is right in the middle of that basic research and getting it out to those in need. Our investments in research are worth a meager fraction of what they would be if they got to all in need, if they're frustrated by what we don't do as a society. I think that's what I hear in the examples, and that's what I think is part of the core story of CDC and getting it out to all those in need.
Absolutely. Well, one of the most challenging parts about a rich agenda for a day like this is we continually run out of time. I would love to have each of you talk a little bit more about your lessons learned, but I think we've had a great discussion. We've talked about the importance of alignment. We've talked about how to get that done in a university setting, how to cross over on a global scale and think not only from our ivory towers here in this country, but how that information and application gets put into use at the local level. And I think more than anything, we've realized that as much as we can work to align and as successful as we can be in aligning within this broad nonprofit sector, when it comes to public health, to the extent that we can align with CDC, they're the hub around which we spin, and to the extent that we can find ways to work with this organization to build it up, the better off we'll all be, the better public health will be, the stronger our economy and our businesses' bottom lines will be. So thanks to all of you today for joining me. Let's hear a round of applause for some wonderful panelists.